Hi, I'm Ralph Preston, and once again, it's Tuesday at 11 a.m. and we're doing our Stroke Buddies Stroke Survivor Support Group meeting. And this week, we've got Dr. Mark McDonald back for the third time. Dr. McDonald's a PhD neuroscientist and a MD medical doctor neurologist. And he runs a company called Centralia that's looking into, I guess they're doing more than looking into, they're developing an AI digital assistant aimed at stroke survivors in terms of preventing future strokes and also providing good patient information. So rather than me tell his story, why don't I introduce Dr. McDonald, who's going to do a little bit of an overview of what they're doing and then maybe a little bit of a demo of the product. And you're welcome to ask questions at any time and would love your feedback. That's what this is all about, trying to make this digital assistant the best it can be so it serves stroke survivors as well as it can. So without further ado, why don't you take it away, Dr. McDonald?
Sounds great. Thanks, Ralph. And maybe just a little bit of background might be helpful. So my passion in my neurology training really was finding ways to use new technology to solve some of the biggest problems that we face as neurologists. And one of the biggest issues beyond stroke for me is the fact that people who know how to diagnose disease, how to manage certain conditions, how to come up with treatment plans and important cogs in the machine of healthcare and evidence-based care are few and far between and really not accessible even in the US. And that gets a lot worse when you look at other countries. So the stats are 1 in 6 people have a neurological disease. There's one neurologist for every 20,000 people in the US. There's one neurologist for every 1.1 million people in India. And there's some countries in Africa with no neurologists. And so how do you take what a neurologist knows and make that accessible to somebody in India, to somebody in Somalia, to somebody here in the U.S. that has a 6-month wait time to get into their neurologist. And so I think first and foremost that's the problem we've been trying to solve for several years now. And for me, stroke made a lot of sense because it's a leading cause of long-term disability. As you all know, it's not just a terrible disease on a societal level, but it on a personal level, it can really upend you and if you're not resilient and don't have kind of the spirit that you all have here at Stroke Buddies, I think it can really do some damage. It can do some damage even if you have that stuff. And so there's effective treatments, there's ways to prevent it, there's ways to better recover from it. But a lot of the problem is getting the exact sort of personalized care into the hands of the patients, getting them the exact personalized knowledge into the hands of the patients. And we're in an era now where we have treatments, but there's a disconnect in how those are delivered. 80 years ago, there were barely any treatments. We had like 5 treatments you could pick, and none of them were very effective, particularly not for stroke. But it's different now. We have a lot of different ways to manage conditions, but we don't have the access is fragmented, the expertise is fragmented, and the knowledge is fragmented. And that's the problem that AI has the potential to solve. There's a lot of problems with AI, and so one of the themes that's going to come up is really what's the place for AI? What's the place for artificial intelligence? And when we say artificial intelligence, really we're talking about a couple different types of things that machines do that mimic human abilities, human cognitive abilities. There's machine learning, which is the ability for machines to learn. There's computer vision, so the ability for machines to recognize visual patterns. There's natural language processing, so the ability to recognize speech language and the meaning behind it. Most of what you've seen in the news recently has been kind of in that last group with ChatGPT and the OpenAI. And then you're starting to see people use a combination of them to achieve pretty impressive things. One of the things that we saw recently was that OpenAI's GPT-4 scored above average on the board examination for medical doctors. We also saw that happen with the, I believe, the bar exam and other tests of what we consider to be relatively rigorous, demanding pattern recognition and knowledge base, that these different types of AI are starting to perform well in very restricted contexts. Not like you can just wheel a computer out and all of a sudden it's taking the place of a doctor, but the performance is pretty scary good in some areas. And so I think it's good. It's important that we're all part of the conversation, that we're all thinking about it, that you all have a hand in how this shapes what we can and can't do with it. And so that's a big part of what we want to tackle today, me and Ralph. So any questions about AI before I get into kind of what we're working on, or any, this is a good opportunity just for anything you've seen in the news or anything that you had questions about. Happy to tackle the high level stuff before we get into what we're working on at Centralia.
Is there any way you can lock in information into the AI so it can't be manipulated? Like ChatGPT, you can convince it it's wrong, or it can convince you you're wrong. Is there any way you can take like medical information and make sure that can't be altered? Yeah.
In fact, let me show you how we do that with that comes up in what we're doing. So that let me when we talk about, because there's actually one of the problems is there's so much processing going on that there's a bit of a delay. So when we're going through the virtual assistant, I'll explain to you how we can solve that problem. But you're right. That's a very good, Gary. That's a very good point. If you just ask GPT-4, so ChatGPT is a type of generative AI. There's different types of models. So if you hear GPT-3 or GPT-4 or ChatGPT, they're all just different types of those under the same company. And what they do is they try to predict a response based on the beginning of some sort of statement or question. And it's, as a result, what happens is if you were just to ask GPT-4 or ChatGPT a medical question, then you can't tell if it's making it up. It can give you an answer that sounds amazing. It actually can make up papers and make up citations, and so you have to constrain the ways you use it. So are you using it to understand what someone wants, or are you using it to actually go out and retrieve information? And so if you can constrain how you use it, you can mitigate the risk of that. But its ability to fabricate and lie is unbelievable. And
terrifying.
Yeah. And this is still something we're working on. Ralph has been working to stump our AI assistant, and there are times where the links don't work, and they'll get some of the words wrong in the link. And we've fixed it where there was a problem where it would make up links, but we were able to kind of go through that. So that's a great question. There's a lot of danger there. I think the difference between where we are now and where we were 2 years ago when you just had Google and search is that you really couldn't understand a request the same way that you can now with GPT-4. So you can understand not only, hey, this person wants this bit of knowledge, but this person may have this emotional reaction leading to this type of question, or this is a deeper kind of implied request with this question. And Google could never do that. That's just on a whole nother level. So very powerful, but very risky. I definitely think I don't recommend using it to search for information. I think it's not very safe. There's some ways to use it that I think are pretty phenomenal, and I'll kind of outline how we use it, and we can that will start a dialogue. But great question, Gary. Any other questions about AI?
Go ahead, Judy, and I got a statement. Oh, you're muted, Judy. While she unmutes, I'll just say I've I've tested. I'm old enough to have watched Johnny Carson, and then where they used to play a little game called Stump the Band. They would give Doc Severinsen a tune to play, and he would play it somehow or another. Always. Hey, I've been playing Stump the Band with the AI, and I've asked it some really tough questions, some ones that I thought might actually require some thinking, and I've been pretty impressed with the information I get back. So it's interesting to hear you say I'm not don't trust it for information, because I found all the information good, and I've got more to say about what kind of information should come back, but that'll be later on in the discussion. Judy, you're unmuted now, so why don't you go?
Yes. What does GPT stand for?
Yeah. So
Good question.
yeah, that's a great question. So GPT, and I actually I'm post night shift, and I'm struggling to pull it up, but it's a generative pre-trained transformer. And I don't understand a whole lot about what that means. It's the way that the transformers is the system that actually Google invented to take massive amounts of language and train these models. So transformer was a shift in how we trained software to recognize language. But I don't necessarily understand the nuance of what a generative pre-trained transformer is. So,
Okay.
Yeah.
Thank you.
Yeah, good question, Judy.
Explain it to you. Bad joke.
What's that?
I said a bad joke. I said maybe we'll get Gary to explain it to you.
And then yeah, so if there are not any other questions, I'm happy to kind of go through and show you sort of what we've done with our virtual care navigator.
So go ahead. Does anybody have any questions they'd like to ask to see what it says about your question? Because Dr. McDonald can type in some, or I can give him some, but be more meaningful for anybody out there if they've got a question to
Can you all see my screen? What screen are you seeing?
popular questions.
Okay. What does anyone have a specific question that they want to?
Oh, come on. I can give you one.
You could ask it how to improve wrist mobility in the affected hand after a stroke.
How to
See what
improve
it advises.
you said wrist mobility?
How to improve wrist mobility in the affected hand after a stroke.
Okay, so Gary, you asked about how we do this. So, and this will take a little bit of time. We're working on the speed of this, but what happens is we actually categorize this as one of 9 types of requests. Are you asking about a goal, improving function, a medical question, an issue with the technology platform? Are you looking for a provider? Are you do you have a question about risk? Do you have a question about some symptoms? So here is what we have right now. So this is the this is just some general stuff that's not super helpful, but so
Well,
general
that's-
strategies.
That's what I'd tell him if he asked me: stretching, range of motion, hand therapy.
And so Gary,
right away, it's recommended you consult a human.
Yeah, I mean, I think that this is, so the way that we use it's a little bit different. So this is, we've got, just for context, we've got a platform where we have physical therapists, occupational therapists, and neurologists. And so this is more front facing. And so we'll provide, the way you can think about this, Gary, is if you call your doctor's office and a nurse answers, they're gonna give you some general advice, maybe a resource, and then they're going to collect information so they can get back to one of the experts. And so this is part sort of a little bit boilerplate advice with some resources, and then also collecting information for our experts. And I can show you that piece. So, this is initially meant to be kind of the in between you and an expert, but you get something now.
Yeah.
So here are the strategies, the way that we're doing this. So sometimes, depending on the question, we'll route it to a database. We'll say, okay, if you had a question about a medical intervention or some sort of medication, then we're going to ask UpToDate because that's the best source. If you have a question about different resources to improve post-stroke function, then we have these 40 vetted resources that are helpful. For strategies, we actually had, we take, this is 2,000 questions that we've generated that our rehab experts, so PTOT speech, have answered, and then we embed that in the model so that gets triggered depending on the type of the request. And so that's what we do here. This is a resource from Flint Rehab for wrist mobility. We can make sure that it works. So
Okay.
Yeah.
I didn't copy and paste them. I was expecting them to be clickable.
And then the next part is we can ask questions, and we're still fine tuning this, but we can ask questions to then better understand your hand symptoms.
One of the things I liked was when it gave you the basic information, it always had a link to the source. So if you wanted to verify it, read more about it, sometimes they're excerpts from longer articles. So I liked having those sources.
And so, we're still tweaking the ability, the types of questions. So our experts, this is one thing sort of under construction, is we're improving these questions. These questions are not as strong as if our experts have trained the model. But the idea here is that we are giving you strategies, giving you a link, and then asking more questions so that our expert can come back to you within 24 hours to make sure that what you got was accurate. We can fill in the specifics based on your particular issue.
That's excellent. Brilliant, man.
So I don't know if we want to do another question. So
Well,
I guess, yeah. Does anyone have another question they want to try?
Like, how long do I do one particular exercise?
What's that?
How long do I do one particular exercise?
I'm not sure I got that one.
And would it be, I mean, it may be a pretty generic answer. Do you have, if you mention your deficit, that might give you more feedback. Like I'm a stroke survivor with this issue. How long do I do a particular exercise might be a way to do it. But either way, I can just do.
Until you can do it perfectly.
And we're still working on the processing speed right now. That's one of the things that we're trying to troubleshoot.
And I've just, for anybody who's interested, I've made this, these are kind of some generic statements, and the second one's kind of the lawyer's statement. I've suggested to Dr. McDonald that they have 3 or 4 of each of these and that they vary them, and that would make it seem a little bit more like you're interacting with a person than a machine. If it didn't always come back and say the same thing before it answers every question.
So this was a little bit different, and we're still tweaking this. So rather than ask you, rather than give you a specific answer that you need to do it this long, it gave you some tips on how to determine the length of an exercise. So, which I think, sometimes with the vague questions, it does have a little bit of trouble parsing out, do you have a goal? And so I think this stuff is helpful. It's probably not as good of a direct answer. So I think that this probably made an error in how it interpreted your request. So we're still improving that. I do think these are still probably useful tips on finding on how to monitor that. And this is a good, the duration. It talks a little bit about the duration here. But that's a good question. So that definitely stumped it. So that was good, Winnie. And so we're still kind of trying to stump it. But this, I think that would have been more of a kind of a prognosis or general question rather than a strategies type of thing. So this is still,
Dr. McDonald?
Yeah.
I have probably a criticism on the general language in this answer. It is speaking of the stroke survivor in the third person, so that this is addressing someone other than the stroke survivor.
Oh, I see. Yes, that's very good.
Use a timer to time the exercise for the stroke survivor. That's very passive, and you've now taken my agency out of this process.
That's a really good feedback.
Good point. I want to say something about vague questions, because there are a lot of vague questions. I'm somebody who answers, I don't know, 100, 200 questions a week in all the stroke groups. And I find a lot of them are vague, and I can't really do much other than what the AI assistant did here in terms of, getting a conversation started. And I would think that the same process might work here as well, asking some follow-up questions and that kind of thing. So if I have a vague question, I'll kind of give some information, but it has to be a broad view, because you don't really know what they're asking or what's going on with them. A lot of times people ask a question like that, they won't say what exercise, they won't say where they are in their recovery, what kind of stroke they had, what they can do and what they can't do. So it's really hard to answer vague questions without some follow-up, because like I said, I answer a couple hundred a week. Not all are vague, but I would say half of them are vague.
And this would be some of the, I do think that, Ralph, that's a great point. And I think we could kind of engineer the questions to sort of help then clarify, the type of exercises. So I do think that is and we're changing this to where you can select multiple, but asking a clarify, and this is a great example of where AI is still limited. Knowing when to ask a clarifying question or not is something that's pretty still kind of safely in the realm of human expertise. Knowing when you're answering a question or when you're switching to I needed more information. And so that is the concept of cognitive flexibility. And the example I always give, when I go into a doctor's office or when I go into the office and I see a patient, sometimes I'm trying to build trust or make eye contact, just develop a connection. There are times when I'm trying to understand what type of person this is. There's times where I'm trying to understand the actual specific symptoms that they had and what that differential diagnosis is. I'm feeding that back into my questions until I feel like I have enough information. And I'm constantly shifting from answering their questions, providing support, to developing connection, to gathering information I need, and I'm surveying, do I have enough information? That cognitive flexibility is something that people can do. And an AI is going to be one of those programs with sort of not very clear parameters on when it was successful, not as clear as a human. And so I think this is a good example of where we're limited with AI, the ability to kind of ask a clarifying question at the right time in the workflow. So, hey, Judy.
Well, what about if you had initially some kind of profile questionnaire that the user had to fill out, so that then the answering part of it could access that profile instead of having to answer all those questions, have a built-in profile questionnaire?
Yeah, that we do have that. That's a great point. And so what we would do is the way that the new models of the GPT models is we can actually take all of that information and put it in a spreadsheet, and then we can search it. So that's a great point, and that's something that we could do, and that would actually help. So I think I think that's kind of the next step for us, is if you're somebody who's using it or has done a questionnaire, you can get more targeted advice. It's a great point, Judy.
That's something I brought up also, Judy, because this version is a lot better than the version a month or two ago. When I first tested it, it kept asking me how long ago was my stroke. I asked it questions. I asked it questions for about an hour, and it asked me how long ago was my stroke about 5 or 6 times. So for one of the first things I said was, to avoid that, because that makes the whole model look kind of stupid. Like it's not, I've been maintaining that the more this thing acts like the nurse, I love that the nurse, the mid-level person, the more it acts like a person would over the phone, the more faith that we're all going to have in it. And, obviously, it's artificial intelligence, but if it acts like a person and gives you good answers, you're going to start to trust it more. And that's, that would be the whole point. So, yeah, I brought that up that either people could sign up, or you could tell who they are by their IP address, even if they don't want to give their name out. It's Judy again, or that woman in Maryland has come back, and let's look up her information. And so it's not asking you stuff, so it can build a little intelligent profile around you and help to better answer your questions.
Go ahead, Ralph. Sorry. Yeah, I didn't mean to interrupt.
No, I won't forget what I'm going to say. I'll bring it up later.
Does anyone have a question about like new types of research or questions about medications? I just want to show you sort of the range of what this can do depending on the type of request.
I got one for you. I have low cholesterol. How come they put me on a statin? I know the answer. You've already answered. You actually answered it. You're the first person that ever gave me a real answer on it. I'm curious. I think I don't remember if I've asked the machine this or not. Perfect. That'll just give people some ideas. I think it'll probably call up some reference articles from American Heart, or some folks, things like that. So maybe you could show them how there's some follow-up to get additional information.
Yeah.
There we go. American Heart Association journals. Yep.
They have an anti-inflammatory effect that can improve blood vessel, stabilize plaques, and prevent the formation of blood clots. So that's a really important. That's a great question, Ralph, because the anti-inflammatory effect is huge, and that's why what you see with statins is the cutoff is really low. It's super low. It's like your LDL of 70 if it's above that. LDL of 90 is great. but LDL above 70, we put people on a high dose statin, not even a regular statin, a high dose statin. It's because of this anti-inflammatory effect. And so this is the article. And so and the way that we do this, so if you were just to ask GPT this question, you wouldn't get an accurate answer. We categorized that it was a clinical question, and we linked it to the right databases, and then we were able to pull the right references. So by restricting the use of, and Gary, I think you'd asked about this, by restricting the use of GPT to not pull information, but just to categorize stuff, and then we go tie that to Google or Google Scholar or all these other resources that we vetted, we can trust, there's more trust that the information that comes back is the right stuff.
Yeah, so it's not trying to generate the information on its own and trying to fill in gaps it doesn't know about, like ChatGPT will. If it doesn't know, sometimes it will try and explain something that it thinks is correct.
So what we do is we pull information. So we limit the function to understand the user's request, shape the query, we pull the information and then summarize the information, but we don't let it just pull information by itself.
Yeah, good.
Yeah.
Cholesterol of 70, I think that would be about 95% of everybody alive. I have low cholesterol because I'm a vegetarian. I had one where I was 65, had 130, but typically I'm 145 or so, and I got like 80 or so of the bad cholesterol. So I got to imagine that would be just about everybody, whether they've had a stroke or not, which is kind of what you find out when you go to look up statins anyway. But the reason I brought that up is this is one of the questions that, for whatever reason, when doctors put you on statins, they don't explain it because it comes up all the time. And the other thing is, a lot of people ask, like I asked about 5 doctors before you explained it to us. For whatever reason, they don't give you much information on why they're putting you on the statin, and I didn't get them to give me a very satisfactory answer or much of an answer at all. One doctor told me on 3 separate visits, because he had a stroke. That's all she would say, because he had a stroke. Okay, that's not really an answer to me, but anyway. So,
Dr. McDonald,
Yeah,
I am interested in learning more about the risk of osteoporosis after a stroke.
very good question. One I've not heard. Does stroke increase your risk of osteoporosis?
Is that how you want to word it, Polly? Does stroke increase your risk of osteoporosis?
Sure.
I'm sorry, I didn't mean to be writing. I didn't. Right after I said that, I saw you typing down below. Good thing I'm not typing him. He touch types. I would say yes. I know a lot of stroke survivors have had teeth issue with their teeth falling apart. So this is the one where I'm suggesting you have 2 or 3 variations of it.
Yeah, I totally agree. I think that's good feedback. And while we're waiting on this, the other
There you go. Well, I learned something today. Sucks, but I learned something.
we should make these links clickable too.
Yeah, that was one of my suggestions.
We didn't quite catch the answer here.
Oh, I'm sorry. Here, this is the answer.
Well, it's I think the issue is that not all of us can see.
Oh, okay.
That may be something in the future to have it be readable and, be clickable, to have the answer read back to you.
Yes, there is that option.
It
I mean,
doesn't.
not yet, but there's that technology is there.
Yeah, it increases your risk of
I will say that this answer it's missing a really important piece of functional deficits.
I mean that the fact that you don't do enough weight bearing and strength exercises and things like that
The studies have shown that it's pretty terrible. You can lose up to 25% bone loss in your femur and up to a third bone loss in your humerus in the first year following a stroke with significant functional deficits.
Right. Yeah.
And
You know that?
I would love to see the medical community moving toward a baseline screening.
That's a great point. Polly.
In the acute period of the stroke, if there are significant functional deficits, because I have osteopenia on my left side. My right side and my spine, I have 30-year-old bones. So I have had no bone loss.
Yeah.
But I have osteopenia on my left side.
So that's so Polly, one of the things we're working on is if this is a mock case, but essentially if when we on our platform, and this is kind of independent of the Stroke Care Navigator, but if we want to aggregate data from devices, Fitbit, or we have actually a partner. I don't know if you know Flint Rehab, but they have a sister company called Tenovi that we're working with.
Flint Rehab.
Yeah. So we're working with their team, and they have a couple devices through their sister company Tenovi, but we're integrating hospital records, wearables data, and then data from you about your function and what your concerns are, what your goals are, what you can and can't do. And the idea here is to really kind of map out what are all the elements we need to focus on. And so that's definitely a great suggestion, Polly. I think that would hopefully be captured here, which is, if you have decreased mobility, then one of the things that need to be a focus area is would be screening for vitamin D would be what we do on the provider side, but then actual kind of activities, sunlight exposure, other things. The activities piece is what stroke survivors or caregivers are kind of asked to be participating in. And so we might get videos. On fine motor function. Flint Rehab has some other content that we're going to be using, but this is stuff that we've made. So this is a card dealing, and so trying to match up, trying to do the doctor things. The doctor things being the checking for vitamin D, getting the lab test, but then there's the exercises and the rehab stuff too. So that's sort of where that would come in, Polly. But that's I love the question. And I think what we want to do is these answers can all be better. And so that's the benefit of having a stroke expert look at it. We also want to, one of the ideas Ralph had was maybe not just incorporate expertise from neurologists and PT, OT, speech, but stroke survivors themselves. What are tips and tricks and strategies that helped in these situations? And so we do want to aggregate, the way that we were able to aggregate that knowledge from all kinds of physical therapists and speech language pathologists and train the model. We'd love to do that with stroke survivors and kind of train the model with tips and stuff and make it kind of more intelligent. It's almost using artificial intelligence as the air traffic controller of different types of human intelligence.
Right. Yeah, that was what I was going to mention earlier, but I knew it would come up again. The other thing is when Polly said that, it made me think of something else, which is, okay, so I thought at first, well, I didn't suggest Polly because I knew that you guys knew each other and you might already be doing, so she might already be testing or whatever. But once it rolls out, if there was a thing where you had at the end of each question, you had an option to for the user to contribute, like, do you have a comment, or do you have additional information, or do you have information as a stroke survivor? That would be a good way to gather some of that information. And people like Polly, see, the thing that I'm not sure that the medical community is aware of that, but when we don't get everything that we want, those of us who are more aggressive about our recoveries and our own data knowledge bases, we go out and search stuff. We're kind of aggressive about that. So some of your high level users are going to be able to provide you with a lot of information. So when Polly said that, she's got something to add. If there was a little comments.
100%. I mean, and probably this wasn't even on my radar, and I've been thinking about this for several years now. So, I mean, and you know, actually vitamin D, we were very religious about checking it in multiple sclerosis, but fatigue is such a problem in stroke. And the fact that osteoporosis is so common, you know, we should be just as religious about checking vitamin D and people with stroke because they have fatigue and they have osteoporosis. So it can make a huge impact on both of those things. So yeah, I do think that's the goal with AI is I know something that some people don't know, but you know something that I don't know and other doctors don't know, and physical therapists know something that we all don't know. And, you know, how do we aggregate that so that we can know all those things? I think that's the vision here.
Allow comments and then have your experts vet the stuff and put it into the database. So in whatever the 9 areas that you look at.
Yeah.
I mean, that's the 40,000-foot view from somebody who knows.
Sorry.
Go ahead.
Says, what does your system have that's not exactly medical information for stroke people, like hobbies, activities, how to do certain stuff, just general information?
I mean, we have, so that's a good question.
Or is it just strictly medical at the moment?
You know, because we tie into some of the online databases that do more than do more than just medical stuff, we can indirectly kind of address some things. I don't know how this is going to go. In the past, I think one of the questions was, how do I improve golf again? And it was able to connect up with a link from an American Heart Association story about a young golfer. And so there is some stuff, but it's not as useful, Gary, as it might be if we had survivors. So this is the answer here. Oh, here we go. This was this is the
This would be a good one for stroke survivor input.
That was actually a pretty good answer.
Yeah, this is the article about the golfer. And so it's we still have a little bit of work to do, but it can you know, I think there's still some value there.
Yeah. So with ChatGPT, I've developed a few different ways of playing guitar after a stroke, and I've been trying to convince ChatGPT how I do it so it can then try and explain it back to us, but I can never quite get it trained enough to understand what's going on. It's always contradicting my information. So if I tell it it's like this, when I know I can do it like this, it will tell me essentially no.
Yeah. Yeah.
I told you we got some sophisticated stroke survivors.
Yeah.
Yeah. I I think the medical community would be surprised at how much effort we put into getting answers for ourselves. And I think this one would be excellent for some stroke survivor input, because I personally know 3 people that are working on trying to get back to golf.
And
Yeah,
Gary, I'd love, or sorry, Ralph, I didn't mean to interrupt. Go ahead. Yeah.
No, it's okay. Gary's, we don't have a golf after stroke group, but we have a guitar after stroke group, which is how I met Gary. He's trying to learn how to play guitar again after his stroke. So I was surprised he asked about golf.
Oh, no, I put that in there because I knew that was a good example. We can ask about
Oh,
guitar.
okay. Well, that would be interesting. Oh, you came up with golf. So he doesn't look like a golfer to me. He looks kind of like me. I'm not exactly a golfer.
But yeah, Gary, I'd love to brainstorm about some ways, because I mean, we're just scratching the surface on this. I think there's some new open source models too beyond OpenAI stuff, and I think there's, we're learning some different ways, whether it's a combination of fine tuning or embedding or vectorizing stuff. So there's happy to kind of swap strategies as you're exploring this stuff as well.
Yeah, if there's any way I can help, have Ralph send me an email address or anything, I can send you information.
Okay.
I can help fill out some holes and sections.
Yeah. I mean, we this is probably.
I can connect you, Gary. Why don't you? I know we've talked through Messenger. Why don't you messenger me your email sometime, and I'll connect you and Dr. McDonald.
I will do that right now.
Okay.
Yeah,
you're
so
like me. I always do it right now so I don't forget or have to write it down.
So these are pretty good. The link is not very good.
I want to look at this.
We still have some misses here, and I think we're trying to
grief.
This pulled up grief. So we missed this one.
It went for the G.
Yeah. So we got tripped up. But yeah, and honestly, team, we are looking for people to help out and happy to reimburse for the time. I think anything from feedback to data you're comfortable with sharing.
I don't require reimbursement. I'm happy to help. I spend a lot of time trying to find people to help with the guitar stuff. But as your AI has brought up, basically what your AI is suggesting is try and bring yourself as close to normal as possible. Either use adaptive equipment or train your hand to get better, whereas the methods that I've developed for guitar completely bypass the disability. If you've got one good hand, it's completely possible.
And I think that's that would be I think that's where we could make improvements, because I do think that there's a best answer that we can train and embed in this, and over time this can be the best. This can be the best resource for the best answers. But it's going to take time to. So that's a great example, Gary, of if we use this and we get there's a better answer, we keep it, we catalog it, we train it, and so the next time the answer is better, and that's kind of the way. Yeah.
How can you encourage your users to give the better answer though, if they have it? If you know what I mean.
How do they what?
So if people have a better answer, how can you encourage them to send it to you? Would you have the text model ask a request?
Yeah, I mean, I think if people wanted to get access to it, we could just would need to sign away. I mean, we're happy to give you all free access to it. We just need to sign a waiver or something saying that this is still kind of in the experimental phase. And if you could just send me an email or snapshots. I can talk to our developers about making sure that we could have potentially a unique identifier. There's some ways we could do it, but we're happy if this is something you all would be interested in to kind of explore. Happy to give you all access. We just need to sign a waiver saying, it's still in development and this isn't take the place of a doctor or something, all that stuff.
Yeah.
Well, it seems like the comment, being able to leave a comment on any given answer you ask, it would be a good way to gather some of that information. And I'm thinking, Dr. McDonald and Gary, that Gary would make a very, very good tester.
Yeah.
If he's Yeah.
I actually do like the idea of leave a comment, or include my tip or strategy. I think that's a great suggestion, Ralph, is a way to just make that more automated so people don't have to do email stuff. So actually, if people were interested in trying this out and just giving free access, let me know. Maybe message Ralph or message me. I think my email's on the invite. I can talk to our engineer about just adding that, so it's easier for you all to do that, so you don't have to send me an email each time.
Well, also it gives you one place to look for it.
Yeah.
I have a question also.
Hey, Gary,
Yeah.
I got your email. Go ahead, Jeff.
I'm over 5.5 years post-stroke, and I have rather severe finger spasticity in my left hand. I'm on baclofen, but the baclofen seems to be worsening it. I would like to know if Dr. McDonald or the AI has alternative suggestions to baclofen.
Botox will probably come up.
I would like to avoid Botox.
Some neurologists don't, well, I shouldn't say this in front of another neurologist, but I had a neurologist at MUSC tell me that as he was injecting Botox into somebody's hand, that a lot of people that administer Botox, typically neurologists, but some other people can, that a lot of people don't either like to give it in the hand or don't know enough about how to give it in the hand. There's something there with Botox. Apparently, if you don't do it right, it can be quite painful also, because he kept asking this woman that he was doing if it was hurting her, and she kept going, "Nope, I'm fine."
So Jeff, I mean, definitely, the hand spasticity is a little bit trickier from Botox standpoint, but I've seen it done. You would definitely want to go to somebody who's very experienced with that. So probably somebody at an academic center that does Botox. Physical medicine rehabilitation, or a neurologist. If you need help, you can message me after this and I can kind of work on helping you get in with somebody. In terms of so this is their answer. Xanaflex is pretty good. I usually give it at night because it can make people drowsy. Clonidine, not so much. The pain component from gabapentin can be pretty helpful. So we see a combination of these. I don't think there's a lot of great data on transcranial magnetic stimulation. Botox it can be very effective. So my answer would be a little bit more specific than that, because I think that they covered their bases as far as established and sort of up and coming treatments, but really gabapentin, tizanidine, and Botox are going to be your best bet.
What was
You
the
can't
first
get
one? Xanaflex? Is that what you said?
Xanaflex tizanidine and Xanaflex is the brand name.
Oh, okay.
Yeah.
What about dantrolene?
Yeah, that's a good question, Polly. I'm not as familiar using dantrolene in this context. My one area of using that is with neuroleptic malignant syndrome, but I have not used it as much with this.
Sorry.
I'll have to send you the article, but it's actually more appropriate post-stroke than baclofen and more effective. I just weaned off of it last month to take a drug holiday. And do you know Dr. Warwick in the PM&R department?
At what facility or what hospital?
UVA.
Dr. Warwick. That name's not super familiar. I mean, we a lot of our docs do Botox themselves, so I don't know Dr. Warwick.
He just completed his residency a year ago.
Oh, well, I haven't been. Yeah, I finished training there 3 years ago, so I haven't been as involved.
He just did my botulinum toxin injections into the lumbricals of my hand a week ago.
Holly, I'm gonna interrupt just temporarily. What was the name of the one you mentioned?
Dantrolene. You do need to be careful of it, because if you are a woman over 40 taking it for an extended period of time, and taking a large dose, it can be hepatotoxic, meaning it can damage your liver. So you do have to have regular liver panel
But that's for
blood
women.
tests.
That's for women.
For women,
Well,
but men?
Mostly women, but it can, those are the higher risk is women over 40.
I was recently moved off dantrolene because I was on it for 3 years and I was never told the risks. And I was never monitored for any type of damage. So I was moved off it about 2 months ago.
Did
How
it
much
work?
were you taking?
I think it was 75 milligrams a day, 3 tablets.
Oh, that's a very low dose and probably very little chance of liver damage from that dose.
Gary, did they check it at least before they started it, your liver enzymes?
No, I got started it within the first month of having my stroke in 2019.
Okay.
And right in the beginning, it made a difference to the tone, but as time went on, I get better movement in my arm once I come off it, because I felt like it was over relaxing me in the end. But when the tone was at its worst, it was very helpful. But I never experienced any bad side effects that I know of. Like my energy levels were dipped, so when I've come off it, I became a lot more hyper productive. But that's the only thing that I've noticed from experience.
Gary, the level they're looking at is 400 milligrams a day is considered the maximum safe dose.
Well, if you're looking, send me that stuff and I can kind of include it in all this.
I will. It's a very old article on the pharmacology of different muscle relaxants.
Okay, I'll look at something more recent. That's okay. But that's helpful. And yeah, I mean, I think this would be great. I mean, if you all were interested in this, happy to give you all access, make sure there's a way to capture better answers. And, Ralph, we could even do something where we design a version for Stroke Buddies that's has a lot of the Stroke Buddies answers embedded in it. So happy to kind of play around with that.
See, to manage the user base, if you were to give it to us, why don't you start an invite-only Facebook group, and whoever gets access to it gets invited in, then it's only people who are using it that can leave feedback.
Say that again, Gary. I'm sorry.
Said, why don't you start a Facebook group that's private, invite only, then you only invite the people in who you gave access, then it's only feedback for users. You don't need to filter through general questions.
That's a good idea. I could do that if Dr. McDonald's interested. I could also make you a part of it, Gary, if you want. If that's something you'd be interested in helping out with, we could
That's
form
fine with Dr. McDonald, yeah.
I would love that. Yeah, that's a great idea, Gary. And
then only let in people that are sort of like want to help out with the development as opposed to the general public.
Yes.
I don't mean general public. I mean the entire stroke survivor population. It'd be pretty easy. You could have a little questionnaire before you let them in with the 4 questions you get off of Facebook, and you could also see who's living up to their membership and who's not.
Yeah.
It's a good idea. Anybody, let me just interject this here. Jeff, or if anybody wants to get in touch with Dr. McDonald, we could put it's pretty simple. Isn't it mmcdonald@centrillo.com?
Yeah, let me just send it through the chat.
You put it in the chat. But if anybody's having any trouble or getting in touch with them, or you come up with some idea, next week and you want to get in touch, you can always get in touch with me. I'm a conduit to various things, including this. I think this has some real future possibilities. I'm encouraging Dr. McDonald to think of it more like an assistant than AI is great, but it needs to be more than a fancy Google search engine, because most of the answers I got were good and they came back relatively quick, even though he's apologizing for those little 2 paragraphs being up for 20 seconds or so before you get the answer. It's still faster than if you typed in something, you don't get the answer, you type in something else, you keep refining your search. That takes longer than this does. But I think it would be really helpful if you could have buttons that said, like, what do stroke survivors say on this issue? Because we tend to put a lot of faith in each other, particularly those who spend a lot of time. We got a number of people.
And there's so much specialization in neurology. I do a ton of stroke, but I'm almost always on the inpatient side, other than Centralia. It's been a while since I've done stroke clinics, so Polly knew a few things that I didn't know, and so I think that's the beauty of this. This is a way to aggregate all these best answers and really take what the collective knows and disseminate that so safely. I think there's a way to do it safely. If we can vet and double, triple check what goes into the model, we can do this safely and just use it to interpret what people are looking for. So
we tend to put a lot of stock in each other, particularly, we all know the people, Polly's got a reputation for doing a lot of research and having good answers and good science. I hope I do. There are a number of us. And yeah, you're seeing people on the way into the tunnel, and all of us are trying to get out the other end of the tunnel, and we're hopefully way in the middle of the tunnel. And we know a lot more about what that darkness looks like than you do, letting in at the, seeing when it first occurs. This is typical. I went back to rehab one time, and they all went, wow, a stroke survivor walking into rehab. I said, what do you mean? You don't get anybody walking in? We don't hardly get anybody ever coming back to visit. We do all these people on the front end, and we have no idea what happens to them. So yeah, I think, in some ways we know a little bit more about what that whole tunnel is like, to stick with the tunnel analogy, because we're the ones that, we live in it. We can't get out of it. We live for the light at the other end.
Dr. McDonald, I noticed one of the questions was, how do I find a neurologist? And I did have maybe a more personal question for you, because you had also mentioned in one of your previous presentations, finding a neurologist that specializes in stroke. I am in the Richmond area and I'm traveling to UVA for PM&R, and I need to find, my current neurologist is a Parkinson's specialist, which has been great since I have a diagnosis of atypical Parkinsonisms from the stroke. So he has been able to really help with that, but not so great for the stroke.
Yeah. So VCU and UVA are solid. I think the challenge is finding the difficulty is it really depends on what you're looking for, and we still have some work to do, Polly, to kind of train the virtual navigator to do this. But I think if you're looking for a resident, or if you're looking for kind of a very experienced person who knows all the literature, has been doing it for 20 years, to look at what's being done right now for you and how your stroke and other issues are being managed and come up with a better plan, then there's somebody that I can connect you with for that. If you're looking for somebody that is accessible, that you can get in to as things arise, they can check with you. Those usually aren't the same person, which is one of the challenges.
Right. Now, and I have gone from my physiatrist, having a physiatrist I loved who was 40 years in and knew everything and, was fabulous, to now being someone who started seeing him when he had just completed his residency. And he has other things to offer. And, the accessibility and responsiveness is, has been great. And, we are learning new things together.
Yeah, I do think that sometimes the residents or the fellows can be even better. I think the challenge is the lack of continuity, because they typically graduate or they finish their fellowship and sometimes they leave, or more often than not they leave. But I do think that a younger person in training that's probably in their fellowship, a stroke fellowship, might be the best in terms of the sweet spot of expertise with accessibility. In that case, I think UVA is going to have better fellows. They have a 2-year fellowship program. So I could always try to work to get you in there. And so just message me and I can help you with that. But the other, the other exception, I guess the other alternative, there's a couple private practice groups in Richmond that are pretty good. The doctors have kind of more of an old school mentality of when that's your patient and you own you own everything about them that they need help with. And because back in the day when you were a doctor, at least a primary care doctor, the clinic was by the hospital. If your patient was in clinic, you go see your patient. If your patient's at the hospital, you go see your patient, and that's your patient, and that's the most important thing. Nowadays, you've got people that are like, oh, I'm only a doctor in this very narrow context, and once you progress to something else, I'm not your doctor anymore. And I think that's a big challenge. And so, but it sounds like you probably want that accessible person that has enough expertise that really is going to go the extra mile and learn new things with you. And that's probably a stroke fellow at UVA, Polly.
That sounds great. And I'm happy to have, like I said, I've had great experiences with both.
Yeah.
I like both perspectives. The person with 40 years experience, I feel like, when I get on an airplane and I look in the cockpit and the pilot's 65 years old, looks like he's been flying forever. That always gives you a good feeling. I've also found that some of the young folks have a certain enthusiasm, and they might also be connected to possibly some newer information. UVA is a teaching hospital, isn't it?
Yeah.
Like I love MUSC because it's a teaching hospital. It just seems a completely different attitude.
UVA and MUSC are really on par in terms of the neurology. The stroke care at MUSC is fantastic. Dr. Chimowitz is one of the leaders in the field. So MUSC is fantastic too. Yeah.
I know Dr. Chimowitz. He was my neurologist before. I've now got Dr. Holmstadt, and I know Dr. Adam. I know all of them down there. And Dr. Couch is doing amazing things at the Stroke Recovery Research Center. I believe it's the only one in the country where they're actually doing triple blind studies on a regular basis. I know there are other triple blind studies, but that's their whole mission, and they've got a whole team of people.
Ralph, I just realized I have a call at 12:15. I'm so sorry to
Oh, no, it's okay. Hey, you're a busy guy, and we most definitely appreciate you sharing your time with us. And like I said, I think this has a real future, and I'd like to see it be more real world than just your basic AI. That's why I'm making some of these suggestions about profiles, comments, stroke survivor, maybe even physical therapist comments. What do physical therapists say? Like, for example, one of the questions I had was, I know you got to go, was about what do you do about knee hyperextension? Well, 2 weeks ago we had 2 weeks ago we had a PT on who Shannon Cobb, who did a whole thing on this. And so there's some people in our network that we could tap. And you've also got PTs and OTs in your
Thank you,
network.
Dr. McDonald.
Yeah,
Right.
yeah. No, it's good to see you, Polly. Good to see you again. And yeah, appreciate it, Ralph and everybody. Yeah.
Yep. We'll let you go. We
right.
appreciate it.
Thanks.
All right.
Thank you.
Thanks.
All right.
Thank you. Bye.